This is your brief video for the Antimicrobial Drug chapter, which is chapter 14 in the OpenStax textbook. So in the last chapter, chapter 13, we had talked about chemical methods and physical methods to control microbial growth. Aside from the antiseptics that could be used topically, those could not be taken internally to help you control microbial growth. Everything in this chapter can be taken internally, and we're going to talk about some of the methods that you can use to administer different doses of antimicrobial drugs. But generally speaking, this chapter is sort of the antibiotic chapter, but antimicrobial drugs are a broader classification of drugs because it includes the antibacterials, the antiprotozoan, the antihelminthic, and the antiviral drugs. They are all part of these antimicrobial drug classifications. So to start us off, one thing you got to wrap your head around is chemotherapy literally just means chemical therapy, and technically antimicrobial drugs are a form of chemotherapy. We have this correlation in our brain that is set up that chemotherapy equals cancer treatment, but really any chemical that you're putting into your body to treat a disease is a form of chemotherapy. And so I just wanted to kind of throw that in there just in case it's jarring for you to see that word pop up here. It just means chemical therapy, and so this of course does go into that purview. While I won't go into everybody who played a role, I did want to mention Alexander Fleming. He's credited as being one of the first people to discover antibiotics, even though he technically wasn't the first. He wasn't even able to purify the drug. There were people who came before him that your book mentions that discovered sulfa drugs and pronicil and things along those lines, but Alexander Fleming discovered penicillin, discovered it accidentally when some of his plates got contaminated, and penicillin was the first antibiotic that did eventually get purified and then used during the wars, specifically World War II, when it was so necessary because there were going to be so many wounded. And so it was one of the first cheap, readily available antibiotics that saved lives that got in use. Now again, he discovered it and he did it accidentally, but other people had to come in after him to mass produce enough of it to be useful. So while he gets the credit, other people were necessary to make penicillin come to market. Okay, some terms that are very important for this chapter and for life in general. Narrow spectrum antibiotics are used to treat specific organisms once you have cultured a bacterial infection in a person and you know exactly what's causing the problem. There are both pros and cons to that, and I've listed some of those on the slide, but most notably, it takes time to figure out exactly what's causing the infection in a person, and so that infection is still happening while you're waiting for the cultures to come back, and potentially the person's getting worse while you're waiting for that to come back. So typically, if you use a narrow spectrum, that treatment gets delayed while you're waiting to find out exactly what's causing the infection. Now, the beauty of this is not only do you find out exactly what's causing the infection, but usually when we do those cultures, we find out exactly which antibiotics they're going to respond to the best so that we can use the best antibiotic that has the best killing with the lowest side effects for that person. So again, lots of pros, but also there's that delay in getting it to the person when we talk about narrow spectrum antimicrobials. Broad spectrum, on the other hand, when you've got a person that is in severe infection and they need help right away, we're going to start IV antibiotics pretty quick when they come into the hospital. The downside to that is because it's broad spectrum, it kills just about everything, and that's going to include your normal flora, aka your normal microbiota. And that's problematic because remember, that normal microbiota does good things for you, and you're going to lose those benefits when you take broad spectrum antibiotics. It makes side effects more likely to occur, and it increases the risks of superbug infections that your book talks about here in this chapter. But you do get that treatment faster. A lot of times what will happen when a person is having a severe infection is when they get into the hospital, we're going to put them on broad spectrum immediately upon entry and then do the cultures. And then once we know more, we're going to put them on a more narrow spectrum antibiotic. Okay, route of administration, I have included some stuff that is not in your textbook, but since a lot of you are allied health majors, you're going to see these abbreviations a lot, so I wanted to go ahead and include them. These are methods of administering antibiotics as well as other meds. So anytime you see the abbreviation PO, that means by mouth. So anytime you send pills or my brain just totally flitzed on me, so sorry. Liquid medications or compounded medications that can be taken in a liquid form, those can be PO, and so that'll be written out on the instructions from the doctor to the pharmacist, but then usually on the jar for the patient it's going to say to take by mouth. Two different abbreviations possible for subcutaneous, SC versus SQ. Subcutaneous means we're using a small or short needle to deliver the drugs just under the epidermis into the dermis of the skin. We're not going deep enough to get into the muscle, so shorter needle again. A lot of our auto injectors, like epinephrine injectors, personally, I take a migraine med that is an auto injector. Those do subcutaneous injections, and so again, SCSQ, that's the abbreviation that goes from the doctor to the pharmacist. IM means intramuscular. Those are longer needles, typically 1.25 to 1.5 inches, although they can be bigger or smaller depending on the weight of the person. This does have to go into the muscle, so that's why the needle is going to be a little bit longer. Usually we do not give IM for the patient to give to themselves, although if it is something that has to be given often, sometimes patients can be instructed on how to give IM injections, and there's videos online. The VA has instructions on how veterans can give themselves IM injections, for example, but usually that's given in a healthcare setting. IV, those are always given in a healthcare setting. And well, I say always, I suppose if the person has an IV set up, they could be instructed in how to put the medication into the pre-existing IV, but we're not going to ask patients to put in their own IV, if that makes any sense. And then topical is just topical. If a person has a rash or something like impetigo, they'll use very often a topical cream that they will smear on the wound. So wanted to give you those abbreviations so that you know them should you see them. You'll probably get those again in like medical terminology or when you get into nursing or EMT paramedic school as well. Okay, another important topic in this chapter is something called selective toxicity. Ideally, whenever a person has an infection, we would like to use a drug that quote unquote murders the bacteria without harming you. So it is selectively toxic against bacteria without being toxic to you. Anytime bacteria have a feature that you do not have, that is a target that we can use to kill them without harming you. So for example, bacteria have a cell wall. You don't. Any drug that targets the cell wall is therefore selectively toxic against bacteria without being toxic to you, barring an immune response or something along those lines. Bacterial ribosomes are smaller than our ribosomes, except for our mitochondrial ribosomes. So as long as the drug doesn't get into our mitochondria, those drugs that affect ribosomes tend to be selectively toxic towards bacteria and not humans. The more selective we can be, the higher the what's known as therapeutic index is going to be for the drug. We want drugs to have a high therapeutic index because that means it's going to give us the best possible outcome for that patient. This is the picture from your textbook that gives you different targets that different antimicrobials are going to use to try to, again, quote unquote, murder the bacteria. These drugs off over here, sorry, I'm pointing at the wrong thing. These cells off over here are going to try to destroy the cell wall, usually the peptidoglycan in the cell wall. So it mentions beta-lactams, which is a big class of antibiotics that includes the penicillins, the carbapenems, all of these types of meds. Vancomycin is the next line. If we are beta-lactam resistant, we tend to go to vancomycin as our next drug of choice. And so on. I'm not going to go through every one of them on this picture right here. So these are the drugs that tend to affect the plasma membrane. Remember that especially the gram-negatives have a different plasma membrane with that lipopolysaccharide layer, and so we can be selectively toxic to their plasma membrane over ours. Their smaller ribosomes are off over here. Their metabolic pathways are different, especially because we can't even make folic acid or folate. Bacteria can, and so we can inhibit their folic acid synthesis, which is one of the B vitamins. And without that B vitamin, they can't harness their energy like they're supposed to. They tend to have different enzymes that stabilize their DNA, replicate their DNA, or transcribe their DNA, and so we can interfere with those enzymes, and that's this class of meds off down here. So anything that they have that we don't, these are the meds that are going to try to mess with that. Okay, now this is the type of slide that I give you that goes with the table. The table I have tried to color code for you. I'm going to back out of this momentarily so that I can show you the table that I have given you. Okay, everything that is in white is the straight antibacterial, antimicrobial. So these are the drugs that we give whenever a person has a bacterial infection. The beta-lactams include penicillin, cephalosporin, and carbapenem. There are other examples, but these are the ones that I'm going to hold you responsible for. Notice that I tabbed those over. Vancomycin is not a beta-lactam, so that's why that's back over left justified. All of these are different classes. The target is, again, is it hurting the DNA? Is it hurting the cell wall? Is it interfering with the metabolic pathway? Whatever. Okay, continuing on, anything that's here in green, these are antifungals. Anything in blue, these are antiprotozoan. All of the pinks are antihelminthics, and the grays are antivirals. And so that's what I tried to do when I color coded that for you, was to show you they're being used against different specific classes of pathogens. There is some overlap, like metronidazole pops up both in the antiprotist and it's an antibacterial. It works against anaerobes, and so that does pop up in a couple different places. But most of the time, something that pops up in one place doesn't work against something else. All right, now coming back up over here. As you're filling out that table, I give you the target, I give you some characteristics, and then for the antibacterials, I tell you whether it's bactericidal or bacteriostatic. For the antifungals, antiprotist, antiviral, antihelminthic, those of course won't be bacterio anything because they're not antibacterials, they're anti those other things, and so that's why I took that column out for those particular chemicals. Okay, I'm going to recommend you follow my PowerPoint for those. Sometimes I give you additional information, and I always cut out some information that the book gives you, so follow the PowerPoints and you'll be okay there. Okay, factors, and I need to flip my settings, pardon me. I forgot because I flunked out for a second. Okay, factors that can lead to resistance. So antimicrobial resistance is a growing problem. Even though it was noticed almost immediately after penicillin was discovered, we were making antibacterials so quickly that it wasn't a huge medical concern. And so doctors would prescribe antibiotics every time you came in. And for 2 generations, essentially, the boomers and the Gen X people, every time we went in, we were given a prescription when we came out. Now, doctors are getting a lot more cautious about prescribing antibiotics, and it's because of antimicrobial resistance. So when you overuse antibiotics, what happens is you are evolving bacteria to be resistant to the chemical that you are trying to use to kill them. Remember that bacteria reproduce so much faster than we do, so they evolve so much faster than we do. And so it does not take them too much time to evolve resistance to specific chemicals. So we've got to make sure we don't overuse antibiotics and prescribe them when not necessary. Subtherapeutic dosing, one of the things that your book mentions is we tend to only consider the age of the individual when we calculate the dosage of an antibiotic, when we might need to consider things like weight. And if weight isn't factored in, the patient might not have enough of the dose going to all of the cells of their body to actually kill all of the organisms, and so they will end up building up resistant populations in certain areas of the body. And that resistant organism, once it starts to build up, it's going to start to cause problems, and then they get a resistant infection. And then a big one that's getting, I would like to say is getting a little bit better now, patient noncompliance. Back in, I would say 20 years ago, if you were given a 10-day course of antibiotics, a lot of times you would take 5 days worth of the antibiotic and then be like, oh, I feel better. I'm going to save the other 5 days for the next time I don't feel good so I can save myself a trip to the doctor. Doing that, again, does not kill all of the resistant organisms that you had in your body. And so it sets you up for a resistant infection in the future. So educating the patient to make sure they don't skip a dose, they take all of the antibiotic, that's a really important component to help break down the chain that leads to antimicrobial resistance. I have linked to this video within Brightspace, Schoology, Canvas, whatever we're using as our LMS at this point. It's a TED Talk by, I think her name's McKenna. She gives a really good breakdown on antimicrobial resistance, and so I recommend that you watch her video. She brings in some other things that the book doesn't mention, like using antibiotics as a growth regulator and factory farming, stuff like that. And so use this TED Talk to help you learn a little bit more about antimicrobial resistance. Okay, this one I'm using just to mention. These are some of the factors that allow bacteria to evolve resistance to antimicrobials. There were three other factors, so 4 in total, but I just chose this slide just because it used the same picture from your textbook. So bacteria can reduce the number of porins or prevent the antimicrobial from actually entering the cell. It can make more efflux pumps to pump more of the antimicrobial out of the cell. Both of those reduce the concentration of the antimicrobial within the cell so that it reduces the killing ability by reducing that concentration. Inactivation by enzymes, the example that I give you is penicillinase is an enzyme that can break down penicillin, or beta-lactamase is an enzyme that can break down any beta-lactam. And then last, if you have an antimicrobial that targets the 50S ribosome, change the 50S ribosome and that antimicrobial can't bind to it anymore. And so that's target modification off over here. So these are the things that bacteria are doing. Again, they're not thinking about it. It's a straight random mutation process. It's evolution at its finest, but this is how bacteria evolve that resistance to antimicrobials. Okay. Another little thing about how once we have that resistance, we can pass that resistance on to the next generation or to other species. When we talk about vertical evolution, that means one organism mutates its genes to evolve a resistance. Again, not consciously, it's not thinking about it, it's just a straight up DNA mutation that happens to confer an advantage. Once we have that advantage, we survive whenever an antibiotic gets taken. So we had this population that was infecting in person. This one had a mutation that gave it resistance. When we started taking antibiotics, we killed off the susceptible cells, but we didn't kill the resistant cells, and so they start to divide and multiply, and we end up with a population of cells that's all resistant to that antibiotic, and they are all related to the original cell. So that's vertical transmission or vertical evolution. Horizontal evolution is a lot sneakier, and it goes back to all those ways that bacteria can transfer plasmids or genes from one cell to another. And that little plasmid right there, our plasmids are plasmids that can carry resistance genes on them. Usually it's an enzyme that's going to bind to the antibiotic and break it down. But if this cell has that plasmid, it's not just going to have one copy of that plasmid, it's going to have dozens or hundreds or sometimes thousands of copies of that plasmid. It can pump some of those out and then share those with other cells in your body. Remember that in your large intestine, you have so many different species that are living in your large intestine. So if this cell picked up resistance, it can share that with this species and this species and this species. And now you have not just one species that's resistant, you have 4 species that are all resistant to that antibiotic. So horizontal evolution allows it to spread to multiple species, and that's where the danger really lies in antimicrobial resistance. Okay, I hope that helped get through some of the sticking points and explain the table. And another note that I will give you is for both the disinfectant antiseptic chapter and this chapter, flashcards are a lovely way to study those chemicals. So make some flashcards or go to Quizlet and see if you can find some flashcards that have been pre-made. I hope that helps you prepare for the next quiz and test that covers this material. Good luck.